Ladies and gentlemen, you are welcome to our next lesson. My name is Moses Wanchiri. Unlike the previous lessons where we have been discussing conditions in psychiatry, this time we are going to discuss some of the medicines that are used to treat the mental disorders. And this time we are going to discuss antidepressants. So we are going to follow the following objectives. By the end of the lesson, we are expected to be able to define the antidepressants, to classify antidepressants, and to describe the mechanism of action of the various types of antidepressants. Now, antidepressants are medicines that are used to treat depression. And this type of medicine take about 2 weeks to start working, and they take about 6 to 9 months for the whole therapy to be completed. These antidepressants are classified into the following. One, we have the tricyclic antidepressants. Then we have the tetracyclic antidepressants, which are sometimes referred to as the atypical depressants. We have the selective serotonin reuptake inhibitor, sometimes abbreviated as Ssris. Then we have the serotonin and norepinephrine reuptake inhibitors, sometimes which are abbreviated as SNRIs. Then we have the serotonin receptor modulators, sometimes which are abbreviated as SRM. Then we have the monoamine oxidase inhibitors that are abbreviated as MAOIs or the MAOs. And then we have the lithium salts. Now, for the purpose of our lesson today, we are going to describe the commonest antidepressants that are used in our hospitals or in our community around here. So, we are going now to describe the indications of the antidepressants. Antidepressants, we said earlier that they are used in treatment of depression. But on top of relieving symptoms of depression, they are used also for the bipolar depression. They are used to treat symptoms of worthlessness, then lack of motivation and concentration. Then antidepressants are also used in the management of anxiety disorders. This is because usually people who have depression, usually depression occurs along with the anxiety disorders. So antidepressants are key in the treatment of anxiety disorders like the phobias, like the panic attacks, like the obsessive compulsive disorders, the eating disorders like the bulimia nervosa, then also nocturnal neurosis. Then they are also used in the management of chronic pain. Then antidepressants are also used in the neuropathic pain in case a person got damage to the neurons or on the nervous system. The antidepressants are also used in the treatment of the neuropathic pain and also post traumatic stress disorders. Now, the mechanism of action of antidepressants will be discussed for particular antidepressants. However, the monoamine hypothesis of depression postulates that depression is due to the deficiency of monoamines in the brain. Now, some of the monoamines, which are also referred to as the biogenic amines, include three classes of catecholamine, which are the dopamine, the norepinephrine, which is sometimes referred to as noradrenaline, and epinephrine, which is sometimes referred to as adrenaline. Now, most of the current antidepressants actually work by slowing the removal of both noradrenaline and the serotonin from the brain. Also, this results into efficacious treatment when there is accumulation to correct the imbalance of the noradrenaline and the serotonin in the brain. Now let us talk about one of the classes which is very common, which are the tricyclic antidepressants. Now, tricyclic antidepressants are named so because of the three-ring atom that make up the major structure of the drug. And the clinical use of the tricyclic antidepressants are major depression, then nocturnal neurosis, and then obsessive compulsive neurosis. Now, the mechanism of action of tricyclic antidepressants is actually by potentiating the action of biogenic amines by inhibition of the reuptake of these amines. Remember, when the impulse has reached the synaptic the synapse, there is always release of neurotransmitters, and in this case they are biogenic amine. But as described in the monoamine hypothesis, which is indicating that depression occurs when there is little of the biogenic amine, then we need to collect and have enough of the biogenic amine at the synapse and or in the brain. Therefore, whatever neurotransmitter, noradrenaline or serotonin that is produced, we inhibit it from being taken or being destroyed or reuptaken. And therefore, whatever is produced will be accumulating until the person's depression will be alleviated. So the tricyclic antidepressants act by inhibiting the reuptake of the little that has been produced, and therefore the person's depression will be alleviated. The tricyclic antidepressants also have both antihistamine and alpha adrenergic blocking actions. The tricyclic antidepressants also possess antimuscarinic actions, and they block the uptake of serotonin. Therefore, we are having this drug being able to accumulate or to correct the imbalance or the deficiency of the monoamines, which is actually causing the occurrence of depression. Now, the pharmacokinetics of the tricyclic antidepressants, they are well absorbed orally, and they are lipid soluble. Then they easily penetrate all tissues and have a long half-life, or they have long half-lives. Then are metabolized in the liver by the liver enzymes, and many of the metabolites are pharmacologically active, and then they are excreted via the kidney. Then the tricyclic antidepressants also act, as we said earlier, they act by blocking the reuptake of the monoamines. So they increase the presence of norepinephrine and then serotonin at the synaptic cleft. These tricyclic antidepressants also cause sedation, and as we said earlier, they have muscarinic effects. So they also act like atropine-like. They have atropine-like actions that may cause dry mouth. Sometimes they can be dry skin. Then there is they cause also blurred vision, and then paralysis of the ciliary muscles, dilatation of the pupils, and then inability to sweat, which is referred to as the androsis. And then we have the urinary hesitancy. Then to the heart or the cardiovascular system, they cause postural hypotension, and sometimes there may be arrhythmias due to depression of the cardiac conductivity. And then tricyclic antidepressants are known to lower the seizure threshold with overdose. So a person who is actually having seizures may have his seizure threshold lowered down, and therefore the person may have a higher frequency of seizure attacks if he was taking tricyclic antidepressants when he is actually known to be having epilepsy. So the adverse effects of the tricyclic antidepressants they resemble those of the phenothiazines, and those are they have both they occur centrally and then peripherally, which are the antimuscarinic effects, which can occur both centrally and peripherally. Then we have also the patient developing prostatic hypertension, and sometimes they may develop what we call glaucoma, and therefore a patient should take antidepressants with the tricyclic antidepressants with caution. Then the tricyclic antidepressants also cause tolerance. Tolerance is taking increasing doses in order to maintain the same level of satisfaction. So people who used to take one tablet may end up needing to take two in order to maintain, to achieve the previous effect that they had. Then these tricyclic antidepressants may unmask a manic episode for a patient who is having bipolar. So tricyclic antidepressants should be given with caution to patients who are having bipolar depression, because they may unmask the manic episode. Then it should also be given with caution to the elderly. Sometimes they are known to cause confusion to the elderly, and then since we say they also lower seizure threshold, they may cause seizures to a person who is having seizures, especially when the tricyclic antidepressants are given in high doses. Then tricyclic antidepressants should not be given along with the monoamine oxidase inhibitor, because they might cause a hypertensive crisis. There might be a lot of overreaction of the person to the two types of drugs. So precaution should be taken, because it unmasks the manic episode for a bipolar patient. Then they have a narrow therapeutic index, and then depressed patients with suicidal intent should be given limited quantities of this drug, because it may predispose them to intense feeling of committing suicide. So those are the tricyclic antidepressants. The next type of antidepressant we are going to discuss are the selective serotonin reuptake inhibitors, the SSRIs. These ones are selectively sensitive to the 5-HT receptors as compared to the norepinephrine transporters, and that's why they are called selective serotonin reuptake inhibitors. So SSRIs, which are the serotonin selective reuptake inhibitor, have little ability to block dopamine active transporters. In addition, they have little blockade activities to the little blocking activities at the muscarinic and the alpha adrenergic and then the histamine receptors. So because the SRIs are relatively safer for use, they are being preferred to be taken. They are being preferred by prescribers to the tricyclic antidepressants and the monoamine oxidase inhibitors. So in case we had all these three type of antidepressants available to us, the prescriber would choose the selective serotonin reuptake inhibitors because they are safer to use, more safer than the tricyclic antidepressants and the monoamine oxidase inhibitors. So the mechanism of action of the selective serotonin reuptake inhibitors are that they inhibit reuptake of serotonin, leading to increased concentration of serotonin at the synapse. And therefore, when we had little and the little that is produced is not reuptaken, then there will be continual accumulation of serotonin at the synaptic cleft, and therefore this one will alleviate the depressive disorder. Then antidepressants, including serotonin reuptake inhibitors, typically take 2 weeks to work, just like we had the tricyclic antidepressants, and they improve mood within about 12 weeks or more. Then therapeutic uses of the selective serotonin reuptake inhibitors, they are used, of course, for treatment of depression, but they are also used for treatment of some other anxiety disorders like the obsessive compulsive disorders, the panic disorders, the generalized anxiety disorders. Then we have also the SSRIs being used for the treatment of the premenstrual dysphoric disorder. This is a type of depression that occurs with severe depression, depressive symptoms, irritability, and tension just before menstruation. And then they are also used in the treatment of bulimia nervosa. These selective serotonin reuptake inhibitors are well absorbed in the gastrointestinal tract. Food has little effect on their absorption, and they are well distributed in plasma and with a relatively long half-life. The metabolism is by the liver and they are excreted in the urine. Adverse effects is sleep disturbance and sexual dysfunction, then suicide, especially among children and teenagers. It has been observed that patients who are treated with the selective serotonin reuptake inhibitors are prone to suicide. So there is great need to take precaution for suicidal tendencies for a person who is taking serotonin selective reuptake inhibitors. Then in overdose, the person may get seizures. Then the other type of antidepressants is actually the serotonin and norepinephrine reuptake inhibitors. Unlike the selective serotonin reuptake inhibitor, this one block the reuptake of serotonin and also block the reuptake of noradrenaline. While the other one is selective to serotonin, this one is blocking both the serotonin and the noradrenaline. Otherwise, the mechanism of action is the same, only that the serotonin and noradrenaline reuptake inhibitor is not selective to the serotonin alone, but it is also inhibiting the uptake of noradrenaline. Then we have the monoamine oxidase inhibitors. Now, monoamine oxidase inhibitors interfere with the action of the monoamine oxidase enzyme, and the monoamine oxidase enzyme is the enzyme that is used for the breakdown of norepinephrine and serotonin. As a result, the neurotransmitter accumulates because the enzyme that is otherwise meant to break it down has been what? Blocked. Now, the mechanism of action is that these medicines inhibit the monoamine enzyme, and therefore, since the monoamine enzyme is rendered inactive, then the monoamines like the noradrenaline and serotonin then will accumulate. So the inhibition mechanism can be reversible or irreversible. In other words, this monoamine enzyme inhibitor can be used reversibly or irreversibly. In irreversible monoamine inhibition, the drug is destroyed within the reaction. Take, for example, if we have this one as our enzyme, and then we have this one as our drug there. This one is supposed to fit here, and when it fits here, it prevents this enzyme, supposing this is the enzyme, and this is the monoamine oxidase inhibitor. This one will fit into the enzyme, and it will prevent it from attacking or the breakdown of the monoamine, which is here, the monoamine that may be present there. And therefore, since this one fits here, this is now the active site, this one fits here, then it will protect the enzyme from destroying the monoamine. And in this case, the monoamine is either the noradrenaline or the serotonin. The serotonin here. And therefore, we are saying that the action of this drug can be reversible or irreversible. In other words, in a reversible reaction, this drug can block the enzyme, and then after some time it will release and then go and block another enzyme, and that is the reversible. But the irreversible reaction is when this drug, which is the monoamine oxidase inhibitor, gets destroyed in the reaction and cannot be used again. And therefore, we are having the monoamine oxidation being irreversible or reversible, whereby in one, which is the irreversible, it is destroyed, and the reversible, they detach, and then the drug can also go and inhibit another enzyme. So those are the two types of the monoamine oxidase inhibitors. Now, chronic administration of the monoamine oxidase inhibitor may lead to what we call downregulation of the V receptors. In other words, the receptors also deteriorate and they become insensitive to to the monoamine. I cannot stop discussing this without discussing the wine and cheese reaction. This one means that there is a fatal interaction when a person takes fermented foods when he's taking the monoamine oxidase inhibitors. The fermented foods are having a compound called tyramine, and such fermented foods are like the wine and the cheese. And in our community here, we have so many other fermented foods. We have like these ones that are made out of millet, which are fermented. So if in case a person is taking the bushera or any other fermented food, yogurt, and then he's also on a monoamine oxidase inhibitor, this one will cause the accumulation of noradrenaline, because tyramine is a precursor for the noradrenaline, and therefore there will be an accumulation of increased noradrenaline in the saturation, and this one will lead to a hypertensive crisis, and this hypertensive crisis may lead to intracranial hemorrhage, and sometimes it may lead also to organ damage. So a person who is on taking monoamine oxidase inhibitors is not encouraged or is prohibited from taking fermented foods. Otherwise, the person may end up with a hypertensive crisis. So the side effects of these monoamine oxidase inhibitors are drowsiness, insomnia, and there might be a fall in blood pressure when the person is changing position. And we come to the end of our session for now. And as we said, we have discussed the antidepressants and we defined what they are. We mentioned, we named the classifications, and then we also named or we described the classification, the mechanism of action of some of the antidepressants. As you could have been listening, you realize that we have not discussed some other mechanism of actions of some of the medicines, especially the tetracyclics, and then the serotonin receptor modulators, and probably the lithium salts. That then leads us to another assignment, that for all the 7 classes that we have talked about today, you are requested to identify 2 medicines for each of the classes, 2 types of medicines or antidepressants. You write them down. Then we need also to know the doses in an adult human being, the doses in an adult when we are treating major depression. For each of the listed classes of antidepressants, name 2 antidepressants, then write the dosage of an adult patient who is having major depression. So we expect to have about 14 statements. And in 1 page, you write that. You write on the heading, we want to see antidepressants, and then we shall have those 14 statements. You write your name and then the student number. Thank you very much, and I hope to find you again in the next session.